So let's go to the next question. For the skeletal traction, simple question which tests whether did you do at least one dressing in the orthopedics posting or not is checked by this question. So for the skeletal traction, which is the pin which is not used and which are used? So very important question, doctor, but before that I like to ask you, what is the need for the traction in a given case of orthopedic trauma? Number one, it aligns the ends of the fractures by pulling the limb into a straight position. It ends the muscle spasm, relieves the pain, and it takes the pressure off the bone and promote the healing. They are all the important purposes. In this, the odd man out is the rush pin. What is rush pin basically? It's an intramedullary fixation device which is used in the case of the open reduction of the fractures in order to maintain the position of the fragments to promote the healing. So rush pins are not the ones that are used for the traction, that the intramedullary pins is what need to be remembered. Then what is the Steinmann's pin? It is placed as what you can see in the case of the left hip soft tissue, which is used for the purpose of the traction. So it is a possibility, it is not the answer. So there is a reason Dr. Rush pin is the answer in this. Let's go to the next question. First for supracondylar fracture of the humerus. So nowadays the examiner is also so routined out that in the same paper 2-3 same topic questions are arising. Now what is the important complication which can occur with a supracondylar fracture? There are 4 major complications in supracondylar fracture of humerus: cubitus varus and Walkman's contracture, vascular injury, and the neurological deficits. They are the major problems which are going to happen is what you need to fundamentally remember. Out of this, the vascular compromise will be seen in about 5% of the children who are suffering from the supracondylar fractures is what need to be remembered, and especially those who have a posterolateral displacement of the distal fragment, they are more susceptible to lead to the development of the vascular injury in a given case of supracondylar fracture. So that's the reason, doctor, what is your possible answer in this given case? You can have a Walkman's contracture, compartment syndrome, and the neurological deficits. These are all the possibilities is what you have to be sure about. Let's go to the next question. Recurrent dislocation of the shoulder. What are the important lesions that you are expected to see? So already we discussed this question in the orthopedics previous 7 years of AIIMS discussion. N number of times this question had arisen. So typically, doctor, there can be a problem with the labrum, that's called the Bankert's lesion. There can be a problem with the bony glenoid, which can be leading to the recurrent dislocation of the shoulder. There can be a problem with the ligaments, where there can be an anterior band of the inferior glenohumeral ligament which can undergo an injury which can lead to the development of a recurrent dislocation. Sometimes there can be a separation of the capsule from the anterior glenoid rim. Hill-Sachs lesion can be there, intra-articular loose body and rotator cuff lesion like a supraspinatus or a subscapularis tear. They all can predispose to the recurrent dislocation is what need to be remembered. So in that case there is no answer in this, because all the 4 can lead to development of recurrent dislocation. Now comes the most common or most possible Murphy's law. So please remember, doctor, 44% of cases it is the bony glenoid problem. Hill-Sachs lesion is in 77%. Capsular separation is in about 85%. So that is the reason, if you take the most common into criteria, D could be a possible answer is what need to be understood. Now let's go to the next question. But before we go, this is the classical AP radiograph of the right shoulder which is showing how the antero-inferior glenohumeral dislocation has happened and it has led to the typical Hill-Sachs defect in the posterior-superior aspect of the humeral head, which is common associated bony lesion is what need to be remembered. Similarly, this shows the relatively rarer type of shoulder dislocation called posterior dislocation, which is rarer than the anterior dislocation. So what you can see here is called the reverse Hill-Sachs lesion is what you will be typically be seeing is what I want to underscore to all of you. Now this is the next important type of dislocation called inferior dislocation of the shoulder joint, otherwise called luxatio erecta, otherwise called the inferior dislocation of the shoulder. What you can see is the arm is abducted, elevated and fixed, and the humeral head is in a subcoracoid position, if you take radiologically, now you know how the anterior, posterior, inferior dislocation of the shoulder typically will be looking like is what I want to underscore. Let's go to the next question. In a given case of the osteochondroma, if there is a sudden development of pain, what is the important thing that you are going to suspect? It can be a fracture, which is not uncommon for an osteochondroma. Similarly, bursitis can develop, sarcomatous change can develop, any of them will present themselves with the onset of the pain in a given case of the osteochondroma. What chances are there in a benign lesion like osteochondroma that malignancy can develop? Around 1 to 25% of chances are there is what I want to underscore to all of you. Most of the times osteochondroma will transform into a chondrosarcoma, is the final sarcomatous degeneration, and it is the painful nature of that mass suddenly is an expression of a sarcomatous degeneration is what need to be remembered. Similarly, fractures, bony deformities, neurological injuries, vascular injuries, a bursa formation with the bursitis and malignant transformation, they are all the complications of the osteochondroma which you are not going to forget. Now I will give you a short case presentation. This is a 24-year-old man who has presented with a hard palpable mass along the medial aspect of the upper calf, and there is a bulbous pedunculated osteochondroma which is arising from the upper tibial epiphysis is what you are able to appreciate over here. Sometimes this simple benign lesion can undergo a malignant transformation where this painless mass in the upper calf can become converted into a painful mass suggestive of the presence of malignant transformation. Now, once more our rule is, there is no question paper without ovarian tumor, cervical carcinoma, bone tumor, brain tumor. So that's the reason, like that if you take 200 questions doctor, out of them 180 questions are standard stock, you are expected to master them without any amount of disparity. Let's go to the next question. Which muscle has got a dual nerve supply? So probably this is a gold medal question while passing you out of anatomy. So which muscle has got a dual nerve supply? Now let us look each of them. Flexor digitorum profundus, the slip number 1 and 2 are supplied by the median nerve, and the slip number 3 and 4 are supplied by ulnar nerve. That's the reason all of you agree that flexor digitorum profundus has got a dual nerve supply. Now once more, if you look at the various flexor muscles of the hand, there are 3 important layers doctor. There is a superficial layer, intermediate layer and a deep layer. That's how you will be dividing it. Now flexor digitorum superficialis, let us examine the nerve supply of it. But before that, what is the way that you want to basically check it? What is the different purpose? You have one flexor digitorum profundus, other is superficialis. Why 2 things are created? What is the difference? Typically hold the finger in extension except the finger which you are trying to test, and ask the patient to flex the finger at the proximal interphalangeal joint, and if the patient cannot flex the finger, then the flexor digitorum superficialis is cut out, is what is the way that you will be examining the flexor digitorum superficialis, which is important for the flexion at the proximal interphalangeal joint, is what I want to underscore to all of you. Similarly, so this is a classical appearance of what you need to remember. Now let us talk about the innervation of the digitorum superficialis. It has no 2 nerves. It has got a median nerve, which is the one which will be basically be innervating it, and it is important for the middle phalanges and at the proximal interphalangeal joint. For the flexion of it, it is required, is what need to be remembered. So there's a reason doctor, what is the answer for your given question? Flexor digitorum profundus has got dual innervation but not the superficialis. Now let us talk about the brachialis. Why brachialis is important? It is the major flexor of the forearm, and it has got an innervation from the musculocutaneous nerve, and in addition to that, around 81.6% of people will also receive the innervation to their brachialis on the radial nerve also. So that is the reason brachialis is having a dual innervation, all of you agree with me. Now what are the muscles in the thigh which also will receive the dual innervation? One membership in cabinet, another membership in one of the government bodies. According to parliament it is not acceptable. So similarly for the muscle it can have 2 chances, 2 opportunities to work. So what are those two different innervations of the muscles of the thigh? Three muscles: biceps femoris, adductor magnus, pectineus. These three can be a minister and also a member of parliament and also the legislative assembly member also. Everything is possible for them. Now let us examine it, because this is one potential question in the tomorrow's exam. In the biceps femoris, there is a long head which is innervated by the sciatic nerve. Short head is by the peroneal division, otherwise called the common peroneal nerves. Common fibular division is the one which is innervating. Similarly, adductor magnus, the part which is arising from the pubic arch is the one innervated by the obturator nerve, and the one arising from the ischial tuberosity is from the tibial division of the sciatic nerve is what need to be remembered. Similarly, pectineus is also supplied by both the femoral and also the obturator nerves is what need to be finally remembered. So now you are all very sure about this fundamental anatomy question, doctor. Brachialis, pectineus, flexor digitorum profundus, all of them are having the dual innervation is what need to be remembered. Actually questions look very simple, answers are not really that simple. So that's a major problem, and in fact it will elicit too much of your gastric acid output when you see, "Hare, I know pectineus, I know superficialis, everybody are my ex-friends, but I don't know which is having dual and singular innervation." I think everybody would have answered, but remember, for everybody it would have been equally tough as you, because there are few things which you have to read, you can't guess in the exam, doctor. Let's go to the next question. Whenever you are giving a retrobulbar anesthetic block, which is the last muscle that is going to be rendered ekinetic is my question to all of you. So what is this retrobulbar injection? Let us talk about it. There is a 1.5 inch needle which is having a rounded tip which is bent at about 10 degrees of angle and being injected, and this will typically leads to the anesthesia within about few seconds is what I want to underscore to all of you. But anesthesia will be to all the muscles but not the superior oblique muscle is what I want to underscore to all of you. Now in the retrobulbar injection of the anesthetic, which is the ganglion which you are trying to block basically in the ophthalmic surgery. It is the ciliary ganglion which is the one which is getting blocked, and that leads to anesthesia of the entire globe so that you can carry on the surgery. So it is the superior oblique which is not the one which gets affected. But some complications also you need to know as a future anesthetist. Proptosis, subconjunctival hemorrhage, eyelid ecchymosis, elevated IOP, they all can become the important complications because of this retrobulbar injection is what need to be remembered. Another important peculiar problem with the retrobulbar injection is it can elicit a oculocardiac reflex. Because of that there is an increased vagal tone and there is a bradycardia and hypotension which can become the further complications. Let's go to the next question. Persistent hyperplastic primary vitreous. What are the important features about it? So basically you need to know it's a relatively uncommon condition and also an uncommon question to appear in the exam. So one common question asked to me is how to bet and bid when there is a negative marking prevalent. You bet on what you are at least reasonably honest that at least I can guess. Something which you have never heard, never touched, it's better not to bet. That's a very important rule. So primary hyperplastic vitreous is not a question like cataract or glaucoma where you can bid when negative marking is there. So what is this basically? It is the lack of the differentiation of the vitreous which will make a undifferentiated vitreous to persist, which is called the hyperplastic persistent vitreous. It is primary, that is idiopathic. There is no reason why it will not differentiate. How do you want to manage? You try to remove that vitreous, because this hyperplastic vitreous, which is retrolenticular in its location, can lead to an opacity in the posterior aspect of the lens and can impede the vision of the child. There is a reason, doctor. In order to improve the visual nature of the, visual acuity of the child, you need to basically remove it. And generally if you look at the particular eyes which suffer from the primary hyperplastic vitreous, they are all microphthalmic in nature is what need to be remembered. So contact lens therapy, aggressive occlusion, they are all considered to be the essential parts of the management. Sometimes this hyperplastic vitreous can become scarred and it can stuck to the back of the lens and areas of the retina, and it can lead to the development of the cataract, retinal detachment, glaucoma, microphthalmia. They're all the important problems is what you need to basically understand. So now you are very sure, doctor, unilateral is true, calcification is true, and it need to be differentiated basically from retinoblastoma by the presence of the cataract, which is not seen in retinoblastoma but seen in the case of the primary hyperplastic vitreous, is what I want to underscore to all of you. Let's go to the next question. Which laser procedure do you want to do for the neovascularization of the iris? Recently we discussed the state AP entrance 2006 question paper also. Diabetic retinopathy, in that you have proliferative, non-proliferative cystoid macular edema stage. In which stage, how do you want to manage is one of the favorite question, because in this country, doctor, diabetes, blindness, they are very closely related to each other. Now let us talk about the rubeosis iridis with the neovascularization. How do you want to manage it? It is the retinal photocoagulation is considered to be the management of choice. What you can see here is the patient is having a diabetic macular edema, and you have basically applied the photocoagulation. At the end of it, there is an improvement of all this edema of the macula, is what you are able to see here. In this given case, you can see all those yellow laser spots which are placed around the optic nerve and the macula. In a given case of the panretinal photocoagulation, which is considered to be the treatment of choice, if there is a neovascularization, is what need to be understood. How do you diagnose the neovascularization? Fluorescein angiography is considered to be one of the best treatment, investigations. What you can see, all those new vessels, which are tiny vessels which are developing around the optic nerve. Once you have done the fluorescein angiography, after doing the neovascular, photocoagulation, you can see the resolution of the neovascularization. So that's the reason, doctor, if there is any area of the retina which is still alive, and it is suffering from hypoxia, that is a wonderful fertile land where neovascularization can develop. Coagulation is a technique by which you prevent that stimulus for the neovascularization by burning those hypoxic retinal areas, is what need to be clearly understood. Let's go to the next question. In the cataract surgery, one of the dreadful complications can be the endophthalmitis. Probably your cataract camp which you have conducted with a lot of mobilization, inspiring the people, was all successful. But later on, the newspaper reported that out of the 50 people whom you have done, around 5 to 10 people have developed endophthalmitis. Finally, you are discredited. Now, how to take care of it and prevent it is a very important challenge. So, this is a typical appearance of how the endophthalmitis, with a lot of vasculature developing due to the inflammation which can develop as a post-cataract complication, is what need to be basically be understood. It is those topical antibiotic eye drops on the day of the surgery is considered to be a very important precaution you have to take to prevent the development of endophthalmitis. Let's go to the next question. Chalazion, especially elderly individual, if it is a recurrent chalazion, regularly patient is coming to you, what do you want to basically suspect? This is one of our routine questions which we discuss on every Sunday test. That's the reason not much of discussion. What you are seeing here, doctor, on the eyelid is the classical example of a chalazion. Now what you are seeing here is a sebaceous cell carcinoma which can have a similar appearance of the chalazion, but in an elderly patient, if a chalazion is appearing, he is a young patient, this is an old patient. In the old patient, if chalazion is recurrent, then you should suspect a sebaceous cell carcinoma, is what I want to underscore to all of you. Let's go to the next question. This question also is from the routine topic, that is the laryngeal carcinoma, but their examiner has twisted and checked you whether you are really scientific before they give you an opportunity to join the nation's most prestigious college. So carcinoma larynx, with the involvement of the anterior commissure and the right vocal cord, with the development of the perichondritis and thyroid cartilage involvement, what is the stage of the laryngeal carcinoma? If you are able to make it out, then you can decide whether radiotherapy, surgery, what I want to do, adjuvant or mainline, what I want to do. So let us have few comments about the laryngeal carcinoma, especially you have three types: supraglottic, glottic and infraglottic. At least glottic laryngeal carcinoma, what is stage 1, 2, 3, 4, let us check it. Typically, the cancer is involving one or both of the vocal cords and the vocal cords are still moving. You have done a bronchoscopy, you have seen for the vocal cords or laryngoscopy, vocal cords are still moving. Then you like to consider it as a stage 1 laryngeal cancer. In the stage 2 laryngeal cancer, that is involving the glottis, cancer has spread to the supraglottis or the subglottis and the vocal cords typically do not move normally. If they are not moving, then it is called stage 2. Then what do you mean by stage 3? The cancer is in the larynx only and the vocal cords do not move normally. That is the reason it already crossed at the stage 2. And the cancer is into the tissues which are immediately next to the larynx is what I want to underscore. And the cancer has spread to one lymph node on the same side of the neck as that of the original tumor. And that lymph node is smaller than 3 centimeters. It is typically called stage 3A is what I want to underscore to all of you. So if it is involving one of the regional lymph nodes, you like to call it as the stage 3, you are all very sure about. Now the question is, in this given case, already the tumor has involved perichondritis with the surrounding tissue involvement. So there is a reason it is no more a stage 1 or stage 2, it has crossed beyond the stage 2. Then beyond stage 2, what do you want to do is a very important question. But before that, what is stage 4? If the cancer has involved the thyroid cartilage with the development of the perichondritis, it is no more stage 3, doctor, it is called stage 4 is what I want to underscore. So now you are having a tumor which is given to you in the stage 4 of the laryngeal carcinoma. How do you want to manage this important condition? You have a lot of choices which are available, garden variety of choices available. Total laryngectomy with radiation you can do, only radiation with or without surgery you can do, a clinical trial of radiation can be done, or you can only do chemotherapy or only radiosensitizer. So like that you have a garden variety of options which are available for you. So out of all these options, doctor, in this given case of nearly stage 4 with the involvement of the thyroid cartilage, giving the radiotherapy, and if the residual tumor is still present, then doing the surgery would be a better choice is what you need to basically understand. Let's go to the next question. What is the most common etiology for the paranasal mycosis? Once more a standard question. Aspergillus can cause varied manifestations, especially we are all living in the era of HIV. That's the reason you can have aspergillus with a vasculitis, with the ischemia of the brain, leading to the development of a stroke, like a focal neurological deficit patient can present to you. There can be a development of the paranasal involvement of aspergillus. A tuberculous cavity can be invaded by an aspergillomas ball. So all these things are possibility is what you need to basically understand. So this gives you how the cerebral aspergillosis, if you can see there is a development of a lot of necrotic areas is what you are able to see here. And how do you describe the fungus called the aspergillus? Classical description. Even if I tell you on telephone as a microbiologist, as a clinician, you must be able to diagnose if you are there in Andaman and Nicobar. It is those 45 degrees of the branching of the hyphae. If they are seen in the microscope, then you need to consider the possibility of the aspergillus. Typically in the lung there can be a development at the autopsy. You can see the presence of how the aspergillus niger can lead to the development of a fungal ball is what I want to underscore to all of you. In the aspergillus microbiology, you need to remember conidophore, which has got a lot of conidia. One more important favorite question of the examiner, which is that fungus with a lot of conidophore formation in an immunocompromised individual. Aspergillus should not be forgotten. And most important is the paranasal sinuses. In a given case of HIV, in the autopsy, you can see the presence of the sphenoid sinus, vascular sinus, to develop sphenoid sinusitis because of all these aspergillus fumigatus. But how did it make an entry into the sphenoid sinus? It is initially invading the paranasal sinuses and later on pervading into the skull. Intracranial compartment is what I want to underscore to all of you. Similarly, in a given case of the rhinosinusitis, because of the aspergillus, if you happen to take typically the biopsy, all the eosinophilic laden fungal rhinosinusitis is something which is unforgettable. Now I will give you a short case history. A 67-year-old farmer who has got a corneal ulcer of the right eye, and he has a history of a small amount of vegetable matter being studded into his cornea, and when the corneal scrapings were done, it shows the presence of this 45 degrees angulating fungal hyphae of the aspergillus fumigatus is something which is unforgettable. And this is a case of 52-year-old man who was working in the metal grinding industry, and there was a corneal foreign body. After a few days, he has developed a lot of inflammation of the eye, and aspergillus fumigatus was grown in that corneal scrapings. Is another classical history of how the eye can become involved, paranasal sinuses can be involved, and the lung can be involved, and the brain can be involved, is what need to be basically be understood. So at the end of it, without knowing what is the treatment, we are not doing the job. Itraconazole is considered to be the treatment of choice in this given case, and intraocular amphotericin with a penetrating corneal graft is treatment of choice in the case of the corneal involvement, is what I want to underscore to all of you. Even in the case of the disseminated aspergillosis, there can be involvement in the heart with a lot of infective endocarditis, vegetation, fungal vegetations which are very massive in size, is another way the aspergillus can express itself, is what need to be remembered. Even there can be a pericarditis which can occur because the aspergillus niger, where it can present like a hemorrhagic pericarditis, is one of the important manifestation. It can involve even the intervertebral disc of the lumbar vertebra, which can lead to development of the lumbar discitis, is what need to be remembered. And it can also involve and pervade into the liver with the development of the recurrent intra-abdominal sepsis which can occur. And amphotericin B is the treatment of choice in the case of invasive fungal infection with the aspergillus, is what need to be remembered. And in the case of the neonates, aspergillus can lead to a primary cutaneous aspergillosis involving the buttocks, is what need to be remembered. And similarly, the burn wounds also can be infected with the aspergillus, as what you are able to see in this given case. And lastly, nails are one thing which are not even spared by the aspergillus. Aspergillus onychomycosis is one important complication which can develop because the aspergillus is what need to be remembered. And after the treatment, there is a resolution of even the nail infection. And finally, it is a double diffusion test, which is a microbiological test where you have a antibody in the patient's serum and the antigen which is already available in your stock solution. You mix them, you can see the presence of the double diffusion. So now you are encyclopedic about aspergillus, doctor. Once more, reading in Harrison infectious diseases is fatal for the exam, doctor. So that is one thing which you should not try out or dream about doing it. At least in MD we did not do that, except in MD final year means tuberculosis and little bit about malaria we read in Harrison, and then go to the exam. Let examiner ask. Examiner by that time already is attritic in his knowledge, and he will remember what Davidson said in 1960s. So one of my senior used to say, why are you reading all this, examiner, if he doesn't know you are having a high chance of failing? So on a lighter vein, but you need to remember, doctor, CMDT and Harrison, for that matter internal medicine, it is not a right choice to read infectious diseases for the entrance. You must be good in your pharmacology about the chemotherapeutic drugs, and microbiology you must be stunningly precise. That's very important. Okay, so let's go to the next question regarding Meniere's disease, which is not a typical feature. Once more, there is a small gulf hole kind of question. This is so all of us know there is a tinnitus, there is a deafness, there is a vertigo. Then why should examiner once more check you about pulsatile and non-pulsatile tinnitus? Now let us be the masters on tinnitus. Next time any question on tinnitus you should answer basically. Tinnitus can be pulsatile, where it is vibratory, where there is a vascular tympanic membrane, or it can be non-vibratory. Now what are all the causes for a pulsatile tinnitus? Like a ENT exam going student, you answer, doctor. If there is any jugular bulb diverticulum or a persistent stapedial artery, and if there is any meningioma, or if there is any adenomatous tumor into endolymphatic sac, or if there are any vascular metastasis. So whatever it is, vascular is the one, a vessel will pulsate, so also pulsatile tinnitus is what need to be remembered. Now you have the acquired conditions of the vessel. For example, if there is any arteriovenous fistula or if there is any fibromuscular dysplasia involving the vessel, and similarly cholesterol granuloma is there in the middle ear, or if there is any intracranial hypertension, they are the other important causes. Whatever it is basically vascular in nature, is equal to pulsatile tinnitus is what need to be remembered. What you are able to see here, doctor, compare the two sides, you can see the presence of a glomus jugulare tumor. Glomus jugulare tumor is one of the important conditions. Characteristic feature pulsatile tinnitus is something which you should not basically forget. Now how about the Meniere's disease? Meniere's disease is the one which does not have a pulsatile tinnitus, it is a non-pulsatile tinnitus is what need to be remembered. Now what are the important drugs that can lead to the development of the tinnitus? Another important question. Bupropion among the antidepressants, quinine, furosemide, propranolol, aspirin, one of the common causes, aspirin, salicylate toxicity can lead to the development of the tinnitus is what need to be remembered. Let's go to the next question. Malignant otitis externa, what is the important cause? Pseudomonas, all of you know very well. Now, though the name is malignant, it is a misnomer, it is not really a tumor or a malignancy. Hence, mitotic figures are not really high. But definitely it is seen in the old people and those who are immunocompromised is what need to be remembered. Now I will give you a short case presentation. A 72-year-old man with a left-sided otalgia, with a otorrhea, with the hoarseness, with the puffiness of the left half of her face. She is also having type 2 diabetes which is poorly controlled, and as an ENT outpatient she was earlier treated as a case of otitis externa. Now you tell me, doctor, such a severe left-sided otalgia with the otorrhea in an immunocompromised and type 2 diabetic individual, what is the important possibility? When the CT scan was done, you compare the two sides, doctor, you can see that the infratemporal fossa and the left mastoid, typically there is an erosion is what you are able to see over here. Though it is not malignant, it is capable of infiltrating the malignant otitis externa, and it can lead to the development of an intracranial complication as the erosion of the bony surface is what you are able to see here. She had been treated with metronidazole, polymyxin. When the oral toilet was done and it was checked under microscope, the pseudomonas has grown, and after about 6 weeks of the antibiotic therapy, you can see that the soft tissue swelling which was there earlier has totally resolved. So this is how pseudomonas, elderly individual, and the malignant otitis externa should not be forgotten.